Welcome to the emdocs.net videocast. On today's video, we'll be looking at some EBM updates for November 2023, and our topic for today is pancreatitis. Let's get to our patient. This is a 45-year-old male who comes in with epigastric pain for 6 hours. He's also had pretty extensive nausea and vomiting. On your exam, he's mildly tachycardic but otherwise stable. You find some abdominal tenderness, but there's no evidence of peritonitis. His labs return, and he has a lipase of over 700. Let's say you also check a right upper quadrant ultrasound. It doesn't show any evidence of gallstones. My question for you is, how much fluid should you give this patient? Pancreatitis is just inflammation of the pancreas. There are a bunch of different causes. In the US, the two most common are gallstones and alcohol disease. Now, you're going to be giving these patients analgesics, antiemetics, but in the past, we used to flood these patients with fluid, liter after liter of crystalloids. The problem is that these patients, especially severe pancreatitis, they're the perfect example of severe systemic inflammation, vascular permeability, and they're at significant risk of volume overload. That brings us to our first paper, Aggressive or Moderate Fluid Resuscitation in Acute Pancreatitis. This was published in New England Journal of Medicine, 2022. It's better known as the waterfall trial. The primary question was, in adults with acute pancreatitis, does moderate fluid resuscitation compared to aggressive resuscitation reduce the development of moderately severe or severe pancreatitis? It was a multi-center, open-label, parallel group randomized controlled superiority trial conducted across 18 centers in 4 different countries. They included patients over the age of 18 years with mild or moderate pancreatitis within 24 hours. They excluded patients with severe heart failure, end-stage renal disease, decompensated cirrhosis, chronic pancreatitis, and also if they had significant electrolyte derangements. They used the Revised Atlantic Classification for diagnosis of pancreatitis. Basically, patients need 2 of the following. They need to have pain that's characteristic of pancreatitis, an amylase or lipase that's greater than 3 times the upper limit of normal, or imaging showing findings characteristic of pancreatitis. Patients were randomized to one of 2 groups. Patients in the aggressive fluid resuscitation group received a bolus of 20 milliliters per kilogram followed by an infusion of 3 milliliters per kilogram per hour. Patients in the moderate fluid resuscitation group only received an infusion of 1.5 milliliters per kilogram per hour. If they were hypovolemic, then they got a bolus of 10 milliliters per kilogram. At 3 hours, all patients underwent a safety check, and if there was suspicion of volume overload, the infusion was decreased or stopped. Patients were also checked at 12 hours, 24 hours, 48 hours, and then 72 hours. The primary outcome was progression to moderately severe or severe acute pancreatitis. The primary safety endpoint was fluid overload. This was defined by pulmonary edema, non-invasive means that diagnose heart failure, or clinical evidence of heart failure. Now, 249 patients were included from approximately over 670 patients that were initially approached for randomization. The median fluid received in the aggressive arm was 7.8 liters versus the moderate group, which received 5.5 liters. Now, as you can see, at all time checks, patients in the aggressive fluid resuscitation group received significantly more fluid. Now, let's get to our outcomes. So for progression to moderate or severe pancreatitis, there was no statistically significant difference. When you look at fluid overload, though, there was a major difference here, 20.5% in the aggressive fluid group versus 6.3% in the moderate resuscitation group. That's an absolute difference of over 14%. When we look at the secondary outcomes, there was no difference in organ failure, local complications, persistent organ failure, respiratory failure, or length of stay. Now, this study asks an important question. We care for patients with pancreatitis. They did use consecutive enrollment, which can reduce bias. it was multi-center and multinational, which increases generalizability. They did do a great job randomizing patients, and they used intention to treat analysis. However, it was open label and unblinded, and this is particularly an issue when you have a potentially subjective endpoint like volume overload. Also, there was some differences in the baseline characteristics. About 66% of patients in the aggressive fluid group had gallstone pancreatitis. 56% of patients in the moderate fluid group had gallstone pancreatitis. Now, this study was stopped early. We've already talked about this a bit in our first video. This potentially overinflates the effect sizes, the estimates, and it leads to more uncertainty. Let's get to paper number 2. This was comparison of clinical outcomes between aggressive and non-aggressive IV hydration for acute pancreatitis, a systematic review and meta-analysis published in Critical Care 2023. And this meta-analysis did include the waterfall trial. They included 9 RCTs with 953 patients. The primary outcome was mortality, and the secondary outcome was fluid-related complications. Patients with severe pancreatitis did have an increase in mortality, but that was not seen in patients with non-severe pancreatitis. However, for fluid-related complications, both severe pancreatitis and non-severe pancreatitis patients had a significant increase in these complications. When you go to the number needed to treat website or the NNT, they found a number needed to harm of 20 for mortality and a number needed to harm of 7 for a fluid-related complication. The bottom line, in patients with mild or moderate pancreatitis, high fluid volumes lead to volume overload. If you have a patient who is euvolemic, then just start off with maintenance fluids. If they're hypovolemic, then give them a small fluid bolus like 10 milliliters per kilogram. Let's get to our next level point for today. That's on hypertriglyceridemic pancreatitis. Now, I had mentioned earlier that gallstones and alcohol disease are the 2 most common causes in the US. Hypertriglyceridemic pancreatitis is uncommon, but it's definitely not rare. It accounts for up to 10% of all cases of pancreatitis, and there are studies suggesting that it's the 3rd most common cause overall. This is defined by acute pancreatitis plus a triglyceride level of over 1,000 milligrams per deciliter, and there's no other causative agent. That cutoff level of over 1,000 is a bit arbitrary, but it's what's generally agreed on. A triglyceride molecule is 3 fatty acids attached to a glycerol backbone. This is how triglycerides are stored in the body. Insulin is a primary factor in how triglyceride molecules are formed and stored. So any sort of condition that increases insulin resistance can result in release of fatty acids, and that can lead to pancreatitis. Now, you might be thinking about diabetes. That's definitely one of the more common causes of hypertriglyceridemic pancreatitis. There are some others like medications, particularly furosemide or tamoxifen or estrogen, also alcohol disease, pregnancy, and hypothyroidism. Your treatment is going to discontinue any medications that can cause hypertriglyceridemia. You can start gemfibrozol 600 milligrams twice a day, replete their electrolytes, and definitely start a gentle dextrose and an insulin infusion. That dextrose infusion can result in an anabolic state and reduce that production of fatty acids. You'll need to titrate that insulin drip based on how insulin resistant the patient is. Finally, you'll want to provide nutritional support. In conclusion, we first looked at fluids in mild and moderate pancreatitis, or the waterfall trial, and finally, we looked at hypertriglyceridemic pancreatitis. Thanks for joining us on the video today, and stay safe and healthy, everyone.